Have you ever seen a patient who can't adduct one eye when looking to the side, but their convergence still works normally? That is classic internuclear ophthalmoplegia, or INO. It's one of the most useful localizing signs in neurology. Today we'll go through what it is, why it happens, how to recognize it, and what it usually means depending on the patient's age. Internuclear ophthalmoplegia is a disorder of horizontal conjugate gaze. It's caused by a lesion in the medial longitudinal fasciculus, also called the MLF. This pathway is most often affected in the pons and midbrain. The key finding is impaired adduction of the affected eye when the patient looks to the opposite side. At the same time, the other eye often shows nystagmus while abducting. Importantly, convergence is frequently preserved. So what does the medial longitudinal fasciculus actually do? It connects the abducens nucleus on one side to oculomotor nucleus on the opposite side. This connection is essential for coordinated horizontal eye movements. When the medial longitudinal fasciculus is damaged, the signal for adduction cannot reach the medial rectus muscle of the ipsilateral eye. That's why we see the classic pattern of failed adduction on the side of the lesion. Let's look at a clear example. Imagine a patient with right-sided internuclear ophthalmoplegia. When they look to the left, the right eye does not adduct fully, while the left eye abducts and often shows nystagmus. On right gaze, the movements may look normal. Convergence is usually still possible. This pattern is highly characteristic. The core clinical features are straightforward. There is impaired adduction of the ipsilateral eye during horizontal gaze, abducting nystagmus of the contralateral eye, horizontal diplopia, and often preserved convergence. This combination strongly points to a lesion in the ipsilateral medial longitudinal fasciculus in the brainstem. It is a powerful brainstem sign. One practical bedside tip: covering the affected eye can sometimes make adduction appear better. This happens because the eye is no longer trying to maintain binocular alignment. However, this is not a diagnostic sign. It's simply something to be aware of during the examination. The most common causes depend on the patient's age. In young patients, especially when the findings are bilateral, think of demyelination until proven otherwise. In an older patient, especially when the internuclear ophthalmoplegia is acute and unilateral, think of a brainstem infarct until proven otherwise. These two patterns are classic teaching points. Not everything that looks like internuclear ophthalmoplegia is true internuclear ophthalmoplegia. Common mimics include partial third nerve palsy and myasthenia gravis. Always consider the full clinical picture and examine carefully. To summarize, internuclear ophthalmoplegia is caused by a lesion of the medial longitudinal fasciculus. It produces impaired adduction with contralateral abducting nystagmus, while convergence is often spared. In young patients with bilateral findings, think demyelination. In an older patient with acute unilateral findings, think brainstem infarct. It remains one of the cleanest localizing brainstem signs we have.
If you found this helpful, like the video and subscribe for more high-yield neurology explanations. Leave a comment if you've seen an internuclear ophthalmoplegia case or if there's another topic you'd like covered next.